that space between critical care and palliative care, where prognosis and communication are so important. And that's what brought her on her way, where she is now studying prognosis, understanding, and trying to shine a light on that for all of us. She's now a T32 palliative care Cambia fellow, and matched with a critical care, pulmonary critical care fellowship, and will be a fellow there next year. So thanks, Whitney. Looking forward to it.
Awesome. Thank you so much, Claire. Let me get started sharing my screen. All right, how are we doing? Can everybody see? Great. Thank you so much, Claire. I'm really excited to be here today. I'm really happy to have the opportunity to present this work that I've been doing with Dr. Creutzfeldt. So the title of my talk is Prognosis Discordance Between Families and Physicians, Dissecting Disagreement in Severe Acute Brain Injury. I have no conflicts of interest. As Dr. Creutzfeldt mentioned, I am funded by the Palliative Care Research Training Grant through the Cambia Palliative Care Center of Excellence. I'll start with framing what we'll be talking about today. I included a brief outline. I'll start by laying some foundation, discussing the relevance of prognostic discordance, reviewing prior literature related to the topic, and explaining severe acute brain injury. The bulk of this topic will focus on our study, Prognosis Discordance Between Families and Physicians of Patients with Severe Acute Brain Injury. And then I'll get into future directions and next steps for this research. Again, I'll start with laying some foundation on why this is important. We all know that shared decision-making has become a cornerstone of practice across disciplines. This shared decision-making depends on mutual understanding. Ideally, a physician communicates medical information in a way that is digestible and interpretable to a patient. In turn, the patient communicates his or her values and preferences about the type of care that he or she would like to receive back to the physician. The hope is that the physician and patient develop a shared mental model regarding both the medical facts and also the patient's wishes. It is worth noting that part of the medical information conveyed by the physician is prognosis and the likely outcomes of various treatment options. Presumably, these treatment options factor into the decisions about the treatment trajectory that the patient ultimately opts for. Based on these conversations, the patient and the medical team arrive at a plan of care that takes into consideration the patient's values with the medical situation at hand. A complicating factor in the case of critical illness is that the patient is often too sick to participate in the conversation and make their own decisions for themselves. In this case, the family is tasked with integrating the medical and prognostic information provided by the medical team with their loved one's presumed goals in order to arrive at a decision. For shared decision-making to be meaningful, patients and physicians, or families and physicians, must align in both medical information and values and preferences. What we will focus on today is to what extent physicians and families align or agree on the medical information at hand. Specifically, we will look at prognosis and to what extent families and physicians hold similar values of a patient's prognosis. Effective communication by the physician and between the physician and the family is clearly a key component of shared decision-making. However, we know these conversations are emotionally and technically challenging for clinicians, for patients, and for families. Clinicians report struggling to balance hope with concern and struggling to gently deliver difficult news. Families have varying levels of preference regarding how prognostic information is received. Moreover, families of critically ill patients do not solely rely on information provided by physicians, but also incorporate their own beliefs about the patient when making conclusions about prognosis. A study in 4 ICUs at UCSF in 2007 found that less than 2% of surrogates formulated beliefs about a patient's prognosis based solely on prognostic information provided by the physician. These surrogates also included things such as the patient's strength, their will, their history, other factors such as how the patient physically looked to the surrogate, and the surrogate's own beliefs and preferences. Finally, some families have difficulty accepting their loved one's prognosis. This has been identified by clinicians as a main barrier to goals of care conversations. Other limitations identified by providers include poor family member understanding of life-sustaining treatments and the limitations of life-sustaining treatments. About 5 years ago, a study was published by a palliative care researcher named Doug White. This looked at prognosis discordance for patients in a general ICU, specifically regarding the likelihood that any given patient in the ICU would go on to survive. It found that families and physicians frequently have differing perceptions of prognosis. In White's study, these differences were attributed to both misunderstandings between the physician and the family, as well as difference in belief between the two parties. Despite some knowledge of prognosis discordance, interventions designed to improve prognostic understanding for families and patients in the ICU have yielded mixed results. One study by Shannon Carson in 2016 found that palliative care-led meetings did not reduce family distress. In fact, they may have had the adverse outcome of increasing PTSD. While there are many potential reasons for this negative trial, it seems safe to say that there are clear gaps in our understanding of communication between families and physicians regarding prognosis. Filling in these gaps will be a key step in facilitating family-physician alignment in shared decision-making. Many of these challenges around prognostication and shared decision-making are intensified in the case of severe acute brain injury. For this reason, severe acute brain injury is a particularly valuable lens through which to study prognosis communication. Severe acute brain injury, or SABI, is a group of devastating neurological conditions that includes ischemic stroke, intracerebral hemorrhage, traumatic brain injury, and hypoxic ischemic encephalopathy after cardiac arrest. A few considerations make SABI a unique disease process. First, patients with SABI often require life or death treatment decisions early on during their hospital stay. Therefore, decisions about prognosis are particularly consequential. Second, due to the nature of the disease, patients are unable to participate in the decision-making process themselves. Family members then are tasked with making these highly consequential treatment decisions by integrating medical and prognostic information with their loved one's presumed goals of care. Finally, prognostic uncertainty is particularly high after severe acute brain injury. Moreover, the question is not so much, will this patient survive, but rather, what would their life look like if they do survive? Specifically, will they be able to interact with others, and to what degree of independence will they maintain? Difficulty prognosticating a patient's recovery after severe acute brain injury makes discussions and agreement around prognosis even more challenging. With that foundation laid, I will move on to talk about our study, which will be the bulk of our talk today. This project on prognosis discordance was part of a larger study run by Dr. Kreutzfeldt called the SUPPORT Study, which is an NIH-funded study that broadly looks at how to better support patients with severe acute brain injury and their families in the neuro-ICU. The question that I specifically wanted to explore was this: how often does prognosis discordance occur between physicians and families of patients with severe acute brain injury? And what predicts this discordance? We wanted to determine the prevalence, etiology, and predictors of prognostic discordance between physicians and families of patients with SABI. We chose to focus on prognosis regarding recovery to independence rather than survival alone, as this seems to be the more pertinent of the two outcomes. Again, SABI not only affects or threatens people's survival, but also their quality of life and their personhood. Patients were eligible for enrollment in our study if they were admitted to Harborview with a diagnosis of severe acute brain injury, had a Glasgow Coma Scale of 12 or less, had been in the hospital at least 3 days, and had an English-speaking family member at bedside. Again, the diagnoses for SABI were ischemic stroke, intraparenchymal hemorrhage, subarachnoid hemorrhage, traumatic brain injury, and after cardiac arrest, hypoxic ischemic encephalopathy. We asked study participants this question: what do you think the patient's chance is of recovering to the point of independence or better? We clarified that independence was the ability to interact with others, feed, and bathe without anybody else's assistance. We showed participants this scale and asked them to mark their prediction from 0% chance or no way of recovery to 100% chance, absolutely they will recover to independence. We asked the family members for their prediction to this question. We asked the physicians for their prediction. And we also asked the family members to estimate what they thought the physician would predict. So after the family member gave his or her own prediction, we presented a second identical scale like this and asked them to mark what they thought the physician would predict. If there were multiple family members present at bedside, the one who took chief responsibility for the medical decision-making in the family was asked to answer these questions. We define prognosis discordance as a difference of 20% or greater between what the family member predicted and what the physician predicted. Prevalence of this prognosis discordance was our main outcome. For example, if the physician predicted that the patient had a 30% chance likelihood of recovering to independence, and the family prediction was around 65%, this would be a difference of 35%. Since this difference is greater than the 20% threshold that we had selected, this family physician pair would meet criteria for prognosis discordance. Conversely, any predictions within 20% of each other were considered concordant. We chose this window of 20% for a few reasons. One, it allowed for subtle variations in prognosis predictions to be treated as concordant. Two, 20% was used in the previous study I described by Dr. White evaluating prognostic discordance in the general ICU. And three, a prior study found that hospitalized patients were substantially less likely to opt for life-sustaining treatments if their prognosis decreased by this window of 20%. Recall that in addition to asking the physician and the family member what they individually would predict, we also asked the family member what he or she thought the physician would predict. And this allowed us to divide overall prognosis discordance into two components. Misunderstanding was defined as a difference of 20% or greater between what the family estimated the physician would predict and indeed what the physician predicted. Belief differences were defined as a difference of anything greater than 0 between what the family predicted and what the family estimated the physician would predict. We chose a difference of greater than 0 as criteria for belief difference because this comparison was between two responses given by the same person. Therefore, any difference between these two responses was intentional. We focused our analysis on optimistic belief difference specifically, as we suspected it would be the majority of cases, and we thought that scenarios in which the families were knowingly optimistic likely would differ substantially from scenarios in which the family was knowingly pessimistic. If belief differences existed, we asked a follow-up question of the family members. Pointing to the discrepancy between the family member's prediction and the family member's estimate of the physician prediction, we asked, what do you think accounts for this difference? This question allowed for a qualitative analysis of one of the components of prognosis discordance, namely belief difference. The question was open-ended, and the response was documented word for word. We asked a few other questions for supplemental analyses. These were a small part of the study, but I will include them here because they provided some interesting results. We also asked the family, how much trust do you have in the information you have received? This was on a 0 to 10 scale. This question was part of a follow-up survey that the families completed independently. We also asked both the physician and the nurse, how would you rate the quality of the family's understanding of prognosis? The response option was a Likert scale with options of poor, fair, good, great, or excellent. It is worth noting that all participants were blinded to all the responses of others, including both these questions and the prognosis questions. Right, so we'll get into the results now. We enrolled a total of 250 patients between June of 2018 and April of 2020. I'm sorry, let me back up. 250 patients were eligible during this period. Obviously, this spanned the pandemic. So while we were enrolling in March and April, enrollment was happening via phone rather than in person. So among these patients who were eligible for enrollment, all physicians were amenable to being involved in the study, but 28 families declined, leading to 222 patients who were ultimately enrolled in the study. Among these 222 patients, 27 family members were unable to predict what the patient's likelihood of recovery was, and 2 physicians were unable to give their prediction as well. This left us with 193 patients for whom we had data on overall prognosis discordance. Again, this was our primary outcome. Among these patients, 20 family members were not sure what the physician would predict. After removing these patients, we had 173 patients for whom we had all 3 predictors, including family and physician prediction and family estimate of physician prediction. So after these numbers, we were left with 173 patients for whom we could measure both misunderstanding as well as belief differences. This table includes the baseline characteristics for the group of 193 patients for whom overall discordance was measured. You can see that the patients on average were 57 years old, while family members were 51 years old. The patients had a slight predominance of men, with women comprising 45% of the sample, whereas family members were predominantly female, comprising 65% of the sample. The majority of both patients and family members were white. Only 23% of patients and 26% of families were non-white. For patients, demographic information was gathered via chart review, and for family members, this information was self-reported. Family members were predominantly spouses and adult children. A few other data points to include here. Patients on average had a GCS of 7, and their disease categories were relatively well distributed between the 5 I mentioned. One other thing that's worth mentioning is that of the 45 physicians who responded to these surveys, the median response was 3 surveys per physician with a standard deviation between 1 and 5. I'll start with a summary of the response statistics. Family members on average gave the most optimistic predictions with a mean of 54%. Family members understood physicians to be slightly less optimistic, on average estimating a physician prediction of 42%. However, physicians were even less optimistic than the families imagined, reporting a mean prediction of 33%. Again, these percentages reflect the likelihood that a patient would recover to the point of independence. The prevalence of overall prognosis discordance, which was our main outcome, was 61%. This means that 119 out of the 193 family physician pairs had a difference in their prognosis predictions of 20% or more. In these patients for whom prognosis discordance was present, the majority had family members who were more optimistic than physicians. We called this optimistic prognosis discordance, and it was present for 99 out of 193, or just over half of patients. This is reflected in the pie chart. The tan section represents patients for whom the family member was more optimistic by a margin of 20% or more. The gold represents patients for whom the family member was more pessimistic by a margin of 20% or more. These total 61%, which is the prevalence of overall prognosis discordance. And the blue section represents patients for whom family members and physicians were concordant. In other words, for 39% of patients, the family prediction and the physician prediction were within 20% of each other. We also used multivariable analyses to explore which patients or family variables might be independently associated with prognosis discordance after adjusting for patient age, disease category, family member gender, family member race, and ethnicity. We found that prognosis discordance was 3.1 times more likely for families who identified as non-white. This was highly significant with a p-value of 0.006. Prognosis discordance was also more prevalent when the family member was a sibling or an adult child. This was in comparison to family members who were spouses. Now recall that we also asked the physicians and nurses, how would you rate the quality of the family member's understanding of prognosis? What we found was that when nurses rated family members as having a poor or fair understanding of prognosis, the odds of prognosis discordance was 3.7 times higher. Interestingly, this was not true for when physicians rated families as having a poor or fair understanding of prognosis. All these associations became stronger when looking at the subgroup of family physician pairs with optimistic discordance specifically, meaning that the family was more optimistic than a margin of 20% or more. For example, optimistic prognosis discordance was 3.5 times more likely for non-white families than for white families, and this had a p-value of 0.003. We found misunderstanding to be present in 80 of the 173 patients for whom we had these data available. Almost half of families could not accurately predict the physician's perception of prognosis. The only independent predictor of misunderstanding, again, was this nurse prediction of poor family member understanding. It's worth noting again here that there was no association, it's worth noting that while there was an association between the nurse perception of family member understanding and misunderstanding, there was no association between physician perception of poor family member understanding and misunderstanding. It's also worth noting that there were no other associations with misunderstanding, namely nothing like patient age, race, family member race, or disease category seemed to be associated with misunderstanding. Optimistic belief difference was present for 94 out of 173 patients, or 54% of patients. Again, this was when the family member's prediction was more optimistic than their estimate of the physician's prediction by any margin. The only independent predictor of optimistic belief difference was physician perception of poor family member understanding. This was interesting. Physicians rated family members as having a poor understanding of prognosis if they had belief differences, specifically if they were optimistic, but not if they had any sort of misunderstanding, and not if there was overall prognosis discordance. The opposite was true for nurse perception of poor family member understanding. And again, it's worth pointing out that there were no other associations, age, race, gender, etc. Okay, so acknowledging that this is a complicated table, I want to walk through a few of the things that we've already discussed. This is the table of our multivariate analyses. You'll see odds ratios and p-values for different variables when looking at overall prognosis discordance. And in the middle, there's a figure with the odds ratios represented by a box and the confidence intervals represented by the blue line. The black line down the center is for an odds ratio of 1. So if the confidence interval does not cross that odds ratio of 1, then these were statistically significant. As I mentioned a few slides ago, the independent predictors of overall prognosis discordance were race, sibling and adult-child relationship, as well as nurse perception of poor family member understanding. When looking at other outcomes, namely misunderstanding and optimistic belief differences, there are only 2 findings that I will point out here. So again, one is for the outcome of misunderstanding, that nurse perception of poor or fair or worse family understanding of prognosis was statistically significant. And conversely, for optimistic belief differences, physician perception of poor family member understanding was associated with optimistic belief differences. One reason I wanted to include this table is that it also highlights what is not associated with our outcomes. For example, you can see that nurse perception of poor family member understanding is not associated with belief differences, and that physician perception of poor family understanding is not associated with overall prognosis discordance or with misunderstanding. Moreover, you can see that patient factors such as age or disease category have no bearing on discordance. Disease category. And then I'll also point out that while there was a trend towards significance for the amount of trust a family had in the information they received and prognosis discordance, it did not meet statistical significance. So again, I'll say that if families had less trust in the information received, there may be a signal that they were more likely to have prognosis discordance, but this did not quite meet our criteria, being just above the p-value cutoff of 0.05. And finally, I'll review the findings from our qualitative analysis of belief differences. Again, this is when we ask family members who noted a difference between their prediction and what they thought the physician would predict. What do you think accounts for this difference? Qualitative analyses of these responses revealed 2 key themes. The first theme was faith. This was demonstrated by family members through comments about their spiritual faith, their faith in the power of optimism, and their faith in the strengths of their loved one. A few representative quotes include, "Doctors don't see the family support. Her family being here for her is going to help her. We know his perseverance, and we also have strong faith. God isn't finished with him yet. And we know she is strong, and she will give all she can to get better." The second key theme was uncertainty. This was captured through quotes such as, "The doctors have to be like that because they don't know. I haven't been through this before. The doctors have done this many times. And it's hard to know what's going to happen because it's so early." We'll move on now to discussion, and I'll start by highlighting a few key takeaways. First, the results from this study indicate that there is a very high prevalence of family physician prognosis discordance for patients with severe acute brain injury regarding their likelihood of recovery to independence. I mentioned earlier that a similar study evaluated prognosis discordance between families and physicians for patients in the general ICU regarding survival. Our study found a slightly higher prevalence of prognosis discordance among the SABI population at 61%, compared to Doug White's study, which found a prevalence of prognosis discordance of 53%. While direct comparisons between the 2 studies are difficult given the different times, locations, and methodologies of the studies, this difference may reflect an increased uncertainty in the SABI population relative to the general ICU population. And third, both misunderstanding and belief differences contribute substantially to overall prognosis discordance. Misunderstanding was noted for just under half of patients, while optimistic belief differences were noted for just over half of patients. One consideration is that misunderstanding may indicate ineffective communication about prognosis on behalf of the physician. Presuming that this is the case, this may be a modifiable component of discordance. In designing an intervention to reduce prognosis discordance, a communication gap could serve as a potential target by improving dialogue between families and physicians. Optimistic belief differences, on the other hand, represent an intentional decision by family members to believe a different prognosis than what they understand the physician to believe. This difference in belief may reflect a feeling of hope, which has been identified as an important coping mechanism, especially in the face of uncertainty. This is corroborated by our qualitative analysis, which indicates that family members choose hope, either for their own benefit or for the benefit of their loved one. Moreover, they say that there is enough uncertainty to justify choosing this hope. This is really important. I think physicians often perceive optimism from families as a false hope that hinders the decision-making process. However, for families, this hope might be a crucial support during a really scary and uncertain time. If that's the case, there probably isn't value in the physician trying to convince a family member of the physician's view if the reason that family's view is different is their own personal beliefs. Again, the understanding of this distinction between the two types of discordance is important when considering which interventions could reduce prognosis discordance. It is likely that any interventions should target misunderstanding and belief differences differently. I'd like to focus for a minute on physician and nurse perception of family member understanding. Physicians seem to rate families as having a poor understanding of prognosis if there were belief differences, but not if there was true misunderstanding or even overall prognosis discordance. Nurses, conversely, seem to rate families as having a poor understanding of prognosis if there was indeed misunderstanding or overall prognosis discordance, but not if there were optimistic belief differences. In other words, physicians seem to misinterpret optimism as physicians seem to misinterpret optimism or hope as a lack of understanding, while nurses more accurately identified true family member misunderstanding. This finding may be related to the fact that nurses spend more time at the bedside than physicians, and therefore nurses may pick up on the subtleties of a family member's interpretation of prognosis. Finally, and potentially most importantly, I would like to review and expand on the finding of racial inequities in prognosis discordance. Non-white family members were over 3 times more likely to experience prognosis discordance than white family members. This was true even when other factors were adjusted for, and it was highly statistically significant. Interestingly, while there was a trend towards significance for both misunderstanding and belief differences, neither stood out as the sole contributor. This association may not be surprising to many. Prior studies have found that non-white patients are more likely to experience poor communication quality with their providers compared to white patients. This is particularly true when the providers are of a different race than the patients. Additionally, non-white race has been associated with lower palliative care utilization. Could these two factors be opening the door for potential misunderstanding? Additionally, non-white families and patients are more likely to experience dissatisfaction with and lack of trust in the healthcare system. Could this be a primer for belief difference? Demonstrating trustworthiness and building trust with non-white families, which potentially includes or presumably includes increasing the proportion of non-white physicians, therefore may be an avenue for mitigating optimistic belief differences. It is worth noting a few limitations to this study. First, data were collected on a single day, and discordance between families and physicians could evolve or improve over the course of a hospitalization. However, this was done because many consequential treatment decisions are made during this time, which highlights the importance of capturing early discordance. Second, only one physician was surveyed. We know from working at a teaching hospital that many providers interface with families and many discuss prognosis. We anticipate that variation between providers in interpretation of prognosis is mitigated by the window of a 20% difference for concordance. We did not track individual physician response rates, and therefore there could be clustering of predictions by physicians. We also did not collect physician demographic data, which may have provided insight into the association between non-white race and discordance. We're getting close to wrapping up, but before we do, I would like to discuss some potential next steps for this work. While these results reveal a lot about alignment or lack thereof between physicians and families regarding prognosis for patients with severe acute brain injury, there are still many aspects to flesh out. Specifically, the finding of nurse accuracy engaging prognosis discordance points to a potential role for nurses in shared decision-making and prognosis communication. More research is indicated to understand the role that nurses currently play in prognosis discussions. Additionally, it isn't clear from the study why prognosis discordance is higher in non-white families. I posited some possible explanations, but further studies will need to explore the roots of this increased discordance. It may be revealing to investigate if higher rates of discordance are present when providers are the same race as patients or family members. Finally, the question remains if and to what extent prognosis discordance even matters. For example, does optimistic discordance lead to specific patient outcomes, such as the use of life-sustaining treatment? Is prognosis discordance associated with higher rates of trachs and pegs in the severe acute brain injury population? Also, does prognosis discordance lead to certain family outcomes? Specifically, could rates of anxiety, depression, or PTSD be higher in family members who experienced prognosis discordance? With this information, we can decide if and how to develop a future intervention to promote alignment between physicians and families of patients with severe acute brain injury, and thereby improve shared decision-making. This has the potential in turn to improve patient and family outcomes. While the results of this study were certainly exciting, there remains a lot to unpack, and I look forward to future work on this topic. There are many people I would like to acknowledge, as this study was the result of hours and hours of hard work by many very, very smart people. The first, of course, is Dr. Claire Kreutzfeldt. Her ideas and prior work in palliative care inspired this project, and she has been a tremendous mentor and source of support throughout. Dr. Rachel Roots-Vamard has been a key collaborator in all aspects of the study, from conceptualizing the product to data analysis and write-up. Leah Andrews did the bulk of the statistical work. Kaylee Duggar was the research coordinator and the main driver of data collection. Dr. Ruth Engelberg's expertise was critical in formulating our qualitative methods and also in qualitative analysis. And of course, I owe a big thanks to the Cambia Center, specifically Drs. Aaron Cross and Randy Curtis, all of whom lended key support for this project. Thank you so much. I would be happy to take questions at this point.
I'll go if nobody else has one. That was so amazing, Whitney, and such helpful research for those of us who work with this population. I was curious about the difference if the surrogate is a spouse or child, or a parent, right? Was that there was
Yeah,
spouse or child?
Adult children and siblings were more likely to have discordance than spouses.
Yeah, and would this be, do we know the ages? Would this be, because I think there's a lot of age differences in how people get their information and whether they're Googling the heck out of things, or if it's related to the relationship. I'm really interested in what your hypothesis is about that.
Yeah, that's a good question. I would wonder if it has to do with time spent at the bedside. You know, I say that, and I also expect that adult children would spend a lot of time at the bedside, but that could certainly be playing a role. That wasn't something that wasn't a piece of data that we included in our data collection or analyzed for that matter. With respect to your comment on age, I will say that patient age was something that we adjusted for in the models. And so even after controlling for patient age, these factors were still statistically significant. We ran into some challenges in multivariate analysis in that we didn't want to control for both patient age and family member age because there were concerns of collinearity there. So we didn't control specifically for family member age, but we did control for patient age, which presumably would translate to family member age given relationship as well. So yeah, I mean, you definitely bring up an interesting point because I think, you know, this was a somewhat exploratory project, and there are so many things, so many new questions it generates, specifically why is prognosis discordance increased in some of these subgroups? So more work to come.
Whitney, this is Grady Payton at the VA. Thank you for that. I was curious, since the data was collected on one day at the very beginning of what undoubtedly were fraught situations, what kind of communication skills do you use to actually ask these questions or present somebody with a scale and say, mark where you think your loved one's going to end up?
It was pretty delicate. And I have to say, I got involved with this project initially just to do data collection when I was an early resident. And I had a lot of anxiety about charging into a patient's room and tracking down their family member after this catastrophic event had just happened to the family, and really trying to pin them down on what a prognosis would be. That said, the conversations ended up going way more smoothly than I expected. And I was surprised by the number of family members who thanked me profusely for coming in and talking to them and just collecting this data. You know, from my standpoint, I was here to collect data, and I really appreciated their involvement, but I didn't see myself as offering anything for them. But it was really remarkable, the number, you know, we had these little like $5 coupons to the cafeteria that we would give them as a thank you for completing the study, and people would say, no, like, I really appreciate you doing this, I can't take your coupon, and all that to say that the conversations were easier than expected. I think families appreciate the opportunity to talk about some of these things with whoever it may be.
Yeah, thank you.
Go ahead.
Just to answer Grady, and it wasn't just whoever. So talking about communication skills, you know, they were people like Whitney who do have communication skills who did it, and this was in person. So these weren't, you know, like age and race we got from a paper survey that they filled out later, but these questions were one-on-one in a private room, away from the patient, sitting down. So a few of the basics that you would be teaching, Grady, were ticked off.
Great, thank you, Clara.
Hi, I'm Jan at VA also, and you've kind of provoked a interest of mine, and I'm curious about whether in your explorations you've looked at the nexus between hope and content understanding. In other words, like we have, you know, there's this sort of, there's this constant impression that like the more the family knows, the more kind of their expectations will line up with the facts, so to speak. And philosophically, that is like a logical thing, but it, there may actually be a fair amount of literature on that that nexus there. So I wondered if you looked into that or planning to, or I'm sure I will now, but.
That's a great question and a fascinating idea. I think I haven't looked into that exactly. I'm trying to think. The question that comes to mind is, are the family physician pairs who had misunderstanding more likely to also have belief? Is there any relationship between those two things? And I haven't looked at that specifically, although thanks to your question, I will plan to investigate that down the road. I am thinking about another piece of data that I didn't include here, which was of all the families who had prognosis, or of all the patients in whom prognosis discordance was present, about a third, their prognosis discordance was simply due to misunderstanding, a third was simply due to differences in belief, and a third was due to a combination. So that actually advocates for a pretty even distribution of how these individual factors contribute to prognosis discordance. But I think that only touches on your question. I think there's still investigation to be done about is there, exactly like you said, some relationship between what the families understand and their measures of hope.
And part of the reason I asked that is that I know I have this problem of assuming that like there's the faith group that's going to be kind of impenetrable, and then there's the kind of science group that we can get on board, and then there's kind of the middle group. And I think that's wrong. I think it's wrong-headed, but it's something that like a trap that we fall into.
Yeah, and that's why I found that finding of the physician's inability to gauge who actually gets it or not so interesting, because I think physicians may be inclined in some circumstances to push and say, family doesn't get it, we need to talk to them more, we need to educate them more, when in reality, the family very well could get it. And in fact, the physicians potentially aren't even picking up on who gets it and who doesn't get it. The physicians are picking up on something, but that something happens to be that the families have optimistic belief discrepancy, meaning they're cognizantly choosing to believe something different than what the physician's saying. So I thought that was a cool limitation on the physician's ability to, come in and diagnose family member understanding.
Whitney, these physicians were largely neurologists and intensivists. It would be really interesting to know where palliative care physicians fall. Are they more aligned with the nurses where they can differentiate this, or do they make the same cognitive errors that the intensivists and neurologists make? Discuss.
Does anybody else have thoughts on that?
Well, I hope we're better, of course. And I feel like a lot of times my role as a palliative care doctor is telling a team, gee, just explaining it over and over isn't going to change their perception, because they actually did hear you. They just don't share your belief. So I hope I'm better, but I would love to be your study subject, Whitney, so that I know.
Yeah, I think that brings up an important issue. And one of the limitations of this study certainly was that we only surveyed the attending physician, when in reality, there are multiple factors in how these conversations take place. And I also think that that will be an important thing to continue to flesh out if the ultimate goal is to determine some sort of intervention which can serve to better align families and physicians. We'll need to understand all the moving parts of that. And certainly the moving parts aren't limited to one family member and and one physician. They do include the nurses, they do include the palliative care providers. I saw Justin's question about chaplains, exactly. Like, these are the things that we need to better sort out in order to ultimately move towards alignment. Just to touch, oh, sorry, Dr. Merrill, did you have something?
Oh, just really quick. I think another benefit of studying that is perhaps it would help us teach that, because I think that's a tertiary palliative care skill, to be able to figure out really where people are. And I'm not exactly sure when I got that, honestly. So I think if we could tease some of that out, that might be helpful.
I think
Oh,
I was just going to say, I think that's right. But I think another really interesting thing about Whitney's findings is that the nurses get it. You know, and it reminds me of Scott Halpern's study showing that if doctors and nurses agree about prognosis in the ICU, they're much more accurate. And it just strikes me that there's this resource there in the interdisciplinary team that palliative care has started to harness, but that a lot of the rest of acute care medicine has not.
Whitney, I'm wondering what questions, I'm wondering if the questions that the palliative care providers ask about understanding upfront, like one of the first questions we sometimes ask is, what have you heard so far from the doctors? And in essence, when you were conducting this study, you were getting at exactly what we hope to get at, I think, as palliative care providers when we go in the room, like, what does patient's family understand? So I wonder if we as palliative care providers are asking similar questions to what you asked the study participants, and that might give palliative medicine providers the advantage or the ability to kind of better suss out exactly what you were doing in your study, who has the belief discordance and who has the understanding discrepancies. So I would hope that we are already doing that work, like Susan said, because, you know, for your study, you had to figure that out. Mm-hmm. And so what you were doing is probably what we should be doing in practice if we are also the ones who are trying to figure that out, right? Because I would say, like, one of the things that surprised me about your study is that only slightly over 50% had that optimistic belief discrepancy, because I think definitely my perception is, oh, it should be a lot more, but it's because I'm coming from that lens of palliative care where those are all the patients that I get consults on, right? Those are all the patients and families that I get called in for, because the physicians are like, they don't get it. They don't get it. You need to come consult on this family. So to see that it's only around half, I'm like, oh, that seems low. But it's because I'm coming from the point of the team that gets called in when that occurs. So my perception is skewed. But you know, I think this study is fantastic. The work that you and Claire are doing is just amazing, and the team is fantastic. But again, I wonder if you are doing that work, and that maybe that's why the families also derived such value from just sitting down and talking to you, because that's something similar to what palliative care almost does, right? We go in a separate room and we talk to families and we ask them what they heard from the doctors, and just give them a chance to almost process in real time, like, what did you hear, and what does it mean to you? And so great study.
Thank you. Yeah, no, I think you're definitely right that the population that the palliative care providers are called in to see is probably slightly different. Although it did make me wonder, as you were saying, that could there be a source of bias in how these data are collected, in that when somebody asks you, what is your belief? And you know that a medical professional is interpreting this response, if maybe people are less likely to mark any sort of belief discrepancy than they might otherwise be. I'm seeing, sorry, Justin, I feel like I haven't had a chance to adequately address your comments. Chaplains on your teams are highly trained to understand. Absolutely, absolutely. No, it would have been interesting. We didn't collect these data, but it would have been interesting to see, actually, I think we did, maybe we just haven't analyzed it, how frequently the chaplains are involved and what the relationship is in between having spiritual support and prognosis discordance. Yeah, I'm pretty sure we actually did collect those data, so it would be cool to go back and take a look and see if there was any sort of signal there.
This is David Grunwald at the VA. Thank you for this wonderful work. And I'm just very intrigued by the subset of this study group that mistrusts and the intersection with belief discordance. It seems like a rich opportunity to really explore what is happening at that intersection and the sort of behaviors that physicians specifically can demonstrate that foster trust. I mean, it would be great if all of a sudden we can flip a switch and have providers of the same race and cultural background, but that's a very long-term proposition. And until we are there, what else can we do that fosters trust? I see studies such as this one as being an opportunity to really unpack that and maybe build a toolkit. And we sense that the palliative care team has that toolkit, but it would really be good to nail that down a bit more and be very explicit about the behaviors that foster trust.
Yeah, absolutely. And that was something I didn't delve into too much for this talk or this study. And probably the reason is because there are still so many questions, like what does this mean, this signal for trust, and why is that the case, and what do we do about it? I agree, it's such a rich opportunity. And I think historically, as physicians, it felt like, well, the family just needs to get on board, the family just needs to trust us, when in reality, exactly like you said, the onus is really on the physicians and the medical team to figure out where the holes in the trust are coming from and what we can do to patch those holes. So I would love to devote more time to exploring those questions.
Thank you.
Thank you. Well, we are about at time, so I just want to thank everybody so much for listening, and thank you for your interesting and thought-provoking questions. And I will be back to keep you posted with any updates I have.
Good job, Whitney.
Thank you.